everyone, respected judges and chairman sirs. Thank you for this opportunity. I'm going to talk about vitreoretinal and choroidal features of rhinoorbital mucormycosis, a longitudinal study. Rhinoorbital mucormycosis is a highly morbid and a rare disease. Recent literature has described retinal findings in the patient of rhinoorbital mucormycosis as central retinal artery occlusion mostly. However, pathological studies have shown mucor invading the choroid and the retina with neutrophilic infiltrates. So it is pertinent that retinal inflammation, secondary to invading mucor, has some role in the microstructural changes seen in vitreous retina choroid of these patients. With evidence of choroiditis, chorioretinitis, endophthalmitis in patients with orbital mucormycosis just limited to anecdotal case reports, there is a need of study of vitreoretinal and choroidal manifestation of these patients in vision-threatening rhinoorbital mucormycosis studied prospectively. SDOCT has an ability to provide optical biopsy of the retinal tissue, and comparing the SDOCT findings with the histopathology of the exentrated globes can help in histopathological correlation. The aim of this study was to describe the vitreoretinal and the choroidal features of the patient with vision-threatening rhinoorbital mucormycosis and how they evolve in time on spectral domain optical coherence tomography. The study should also provide insight into the pathophysiology of these vitreoretinal and choroidal manifestations by in vitro analysis of the exentrated orbital content. This was a prospective observational study carried out at GTB Hospital, New Delhi. 15 consecutive microbiologically, radiologically, histopathologically proven patients of rhinoorbital mucormycosis having acute loss of vision, secondary to posterior segment pathology, not attributable to any other systemic illness the patient had, were included in the study. The outcome measures were retinal thickness, prevalence data of the SDOCT features, and histopathological correlation. For the inclusion criteria, a normal carotid Doppler and normal echocardiography was also must. All recruited patients were treated with standard treatment guidelines. Complete ophthalmic examination, including best corrected visual acuity, color fundus photograph, serial OCT, were done on weekly basis for 2 months. Central macular thickness, inner and outer retinal thickness measured 1 mm nasal to the fovea, with total retinal thickness measured 1 mm nasal to the fovea, were recorded at all visits. Patient with absolute loss of vision, extensive orbital involvement, loss of enhancement of orbital tissue on MRI, underwent orbital exentration. The exentrated orbital content was sent for histopathological evaluation. The 4 patients in our study, in our cohort, underwent orbital exentration. The minimal follow-up was of 1 week with the maximum follow-up of 11 weeks. The features like ILM detachment, inner retinal hyperreflectivity, inner retinal thickness, which has been described previously in patients with on OCT on previous patients with CROA. There were features like vitreous cells and vitreous haze, posterior hyaloid thickening with partial detachment, ill-defined optically empty spaces, hyperreflective dots in the outer nuclear layer. The vitreous haze, the vitreous cells, the posterior hyaloid thickening, ill-defined optically empty spaces, hyperreflective foci was seen best at the 4 week, or rather they were most prevalent at the 4 weeks, while the focal RP disruption was seen at the end of 2 months. This is the serial fundus photograph of patients showing retinal thickening, ILM detachment, inner retinal hyperreflectivity. Apart from that, we see focal optically empty spaces at the end of 3 weeks, which diminished on further follow-up, leading to optic atrophy. On the left-hand side, we see an OCT showing choroidal scarring, vitreous cells, vitreous haze, thickening posterior hyaloid. The histopathology of this patient showed thrombotic angioinvasion with disorganized retinal architecture. Apart from that, hyphae was seen in the mucor hyphae was seen in the choroid with neutrophilic infiltration in the retina. Another patient, apart from the inner retinal hyperreflectivity with progressive thinning, there was vitreous cells present over the disc. The histopathology of this patient revealed thrombotic angioinvasion of the disc vessels. The retinal thickness matrix, there was decrease in the progressive retinal thickening decrease from the thickened retina at the beginning with thinned out retina in the last follow-up. So the fundus images of this patient were consistent with the central retinal artery occlusion. However, the SDOCT finding that has been described in the previous case reports or the literature was consistent with the SDOCT findings of CRAO. Vitreous cells, protein-rich vitreous haze, and posterior hyaloid thickening are the feature of posterior segment inflammation. Vitritis associated with retinitis is dependent on the immune status of the patient. Most patients in our history had the history of diabetes mellitus and a steroid intake associated with dampened immune response. Thrombotic infarction of the retinal arteries could be the reason for minimal vitritis seen in our patients. These focal empty spaces have also been described in necrotygic retinitis. Necrotygic viral retinitis have these empty spaces because of the necrosis by viral-induced cytolysis and vascular occlusion. However, in our study, these necrotic spaces could be a spectrum of coagulative necrosis secondary to the vascular occlusion. The focal area of coretal scarring could be a sequelae of local inflammation caused by the mucor hyphae. Histopathological examination also revealed mucor hyphae in the choroid and with intense neutrophilic infiltrates. Thrombotic infarction of the vessels by the mucor hyphae may precede the direct invasion of the occlusal course by the mucor, because sclera acts as a natural barrier for the invading mucor. So the sites for blood vessels and the nerve piercing the sclera could be potential weak point. That is the reason we saw vitreous cells at and around the disc. So in conclusion, I would like to conclude with early microstructural changes were primary result of retinal infarction secondary to thrombotic angioinvasion, while the late microstructural changes could be a possible sequelae of retinal infarction with sub-contribution from inflammation resulting from mucor invading the choroid and the retina. Thank you.
Thank you very much for nice presentation. Any specific finding you could see with this on OCT, which is suggestive or which is helping
Sir,
you in
previously what has been described in literature is just the findings which are suggestive of central retinal artery occlusion. They have not described vitreous cells. They have not described. These optically empty spaces. They have not described thickened ILM. So these are thickened posterior hyaloid. Sorry. So these are suggestive of inflammation. So none of the OCTs previously have described them having inflammation. So we did a histopathological examination which showed mucor in the retina, mucor in the choroid with neutrophilic infiltrates, and these OCT which provides the optical biopsy showing the same things. So we hypothesize that these patients do not just have CRO. Everything that looks like CRO is not CRO. There is certain component of infective inflammation because of the mucor happening in this eye. This was the outcome of this study, that it is just not the CRO. Every picture that you see in a mucor is not CRO. Do an OCT, try to see these patients. You might find inflammation, you might find these cells, and these cells are suggestive of some reaction by the mucor. Although the response in these patients are dampened compared to the normal patient because of the diabetes mellitus, thrombotic angioinvasion, but overall they do have an inflammatory response. So the prerequisite in this study was that all the patient with vision threatening rhinobilateral mucormycosis. So most of the patient with vision threatening rhinobilateral mucormycosis have to have an posterior segment involvement. So the most of the patient that were almost all the patient who presented with CRO were taken in the study, because we wanted to say that this is not CRO only. Come on. So what they say is that there is a perineural spread. One, second is that happens the sclera acts as a barrier. So, but the sides where these peripapillary vessels come up, these are the potential weak point in the sclera. So the mucor invade the sclera. That is why I showed one picture which has a thrombotic invasion with the cells over the disc. So cells were predominantly seen more on the side on the disc, because these are the potential site. Sclera being the barrier, that is why we had thrombotic angioinvasion CRO first, followed by the inflammatory and the mucor invading the choroid.
I think we'll go ahead with the next one.
Thank you, sir. Thank you for hearing me out.
The next, I invite Dr. Femin.
Good morning, everyone. I'm Dr. Femin Susan Tide, Shankara from Shankara Eye Hospital, Coimbatore. No, sir. No. correlation of macular perfusion with visual outcomes post-retinal detachment surgery. Retinal detachment is the separation of neurosensory retina from the retinal pigment epithelium, and it is one of the leading cause of permanent loss of vision if treatment is delayed. Visual outcomes after anatomic reattachment can vary from poor visual acuity, color vision defect, and persistent metamorphosia, especially when macula is involved. Rhegmatogenous retinal detachment disturbs the retinal and choroidal circulation as well as metabolism. So the aim of this study was to explore the macular perfusion changes using OCTA-derived indices in eyes with macula of rhegmatogenous retinal detachment post-pars plana vitrectomy. Next, we also evaluated the difference in the macular perfusion with the fellow normal eye. And we also evaluated the changes in these indices during the follow-up period of 3 months. We have included all the patients who had unilateral macula of rhegmatogenous retinal detachment post-pars plana vitrectomy with gas tamponade. All age groups of patients were included, and eyes with single surgery anatomic success were included. Exclusion criteria include best corrected visual acuity of less than 6/36 in the unaffected fellow eye, and in postoperative macular complications like epiretinal membrane, cystoid macular edema, all were excluded, and concomitant ocular diseases like diabetic retinopathy, glaucoma, and ARMD were all excluded, and postoperative complications like redetachment and proliferative vitreoretinopathy were excluded. Materials and methods. The first assessment was done 1 month post-operatively, that is following the disappearance of the gas, for best corrected visual acuity for distant vision using logMAR equivalent of Snellen's chart, and slit lamp examination was done, and fundus examination with indirect ophthalmoscopy, OCT angiography, 6 into 6 mm cube imaging of the retina centered around the fovea using Cyrus HD OCT was done. Similar examination were performed for the fellow eyes as well, and follow-up was done 3 months post-operatively. This is an image of superficial capillary plexus of normal eye, superficial capillary plexus of abnormal eye at 1 month visit and 3rd month visit, and deep capillary plexus image of normal eye as well as abnormal eye at 3rd month visit. Our results, according to the age group, most of the patient belong to the age group of 56 to 65 years old, around 41.67% of patients, and gender, there was a male predominance in our study, around 61.11%. Best corrected visual acuity was significantly lower compared to the normal eye, as you can see in the bar graph, in 1 month, and it improved in the 3rd month follow-up visit. Superficial perfusion density was also less at 1 month visit compared to the normal eye, and it improved in the 3rd month visit. Deep perfusion density was also decreased from a mean of 24.09% in normal eye to 22.29 in the abnormal eye in the 3rd month visit. So this is a data of the 3rd month follow-up visit showing the superficial and deep perfusion density, and you can see that there is a statistically significant correlation with the deep vessel perfusion density. Then we correlated with the visual acuity of the superficial perfusion density, and it was found that there was a positive correlation with the visual acuity and deep perfusion density. It was found that again there was a positive correlation. So discussion, from the study we could infer that the macula of rhegmatogenous retinal detachment may cause not only retinal and structural damage but also decrease perfusion, retinal perfusion even after successful anatomic repair. This study could demonstrate that the vessel density in the superficial capillary plexus and deep capillary plexus of the retinal detachment eyes were lower than the fellow unaffected eyes after surgical treatment. A statistically significant reduction of perfusion density in the deep capillary plexus was also noticed. We found only a small reduction in the perfusion density of the superficial capillary plexus that did not reach a statistical significance in the 1st month follow-up as well as the 3rd month follow-up. And this might be expected because superficial capillary plexus supplies the region less affected by retinal detachment. We could also find a significant statistic positive correlation between the final best corrected visual acuity, perfusion density of the superficial and deep capillary plexus. conclusion, the quantitative OCT analysis confirmed that the postoperative perfusion density in the superficial and deep capillary plexus decreased in macula of rhegmatogenous retinal detachment eyes compared to the fellow normal eye, and the recovery of microstructural and microcirculation parameters over the time indicates a potential improvement of retinal function, and evaluation of the retinal microcirculation using non-invasive OCT angiography could be a potential indicator for explaining the different postoperative visual outcomes in retinal detachment patients. Thank you.
Singh?
Good morning, everyone. Good morning, judges. Good morning, chairperson. Good morning, everyone. Myself, Dr. Subodh from Iris Super Specialty Eye Hospital, Ranchi. So we did a study of incidence, severity, and treatment outcome. So my study was a yes. My study was the incidence, severity, and treatment outcome of advanced retinopathy prematurity in babies born with assisted reproductive technology. So, as we know, the ROP is a disease of retinal vascular and capillary proliferation affecting the premature baby, and India is currently facing an ROP epidemic as because the more of premature baby because of the ART. So we did this study. Our study was a retrospective observational study at IRIS from January 2018 to January 2022. We just followed the screening guideline. We took the babies born less than 200 gram, gestation is 34 weeks, or those babies 34 to 36 weeks with exposed to the factors as prolonged supplemental oxygen, respiratory distress, or blood transfusion. We have followed the international classification for ROP guidelines were used to record the stage of the disorder, location of zone, and signs. Plus spectrum disease. Data were analyzed with the gestational age, birth weight, systemic factors to ROP, and statistical analysis were performed using SPSS software. So this is one of the baby we got like in ART baby, just a zone half ROP. We treated this baby with the anti-VEGF injection followed by laser. That is a complete recovery ROP in this one. So we had 474 babies. Among them, 272 were natural conception and 202 were ART. The mean gestational age in conception was 32. Otherwise, in ART is 31, which was significant. And we saw that the ART had a lesser gestational age babies. Again, with the birth weight, also the ART baby has a lesser birth weight compared to the conception one. In ROP, we got 88 out of 237 in natural conception were 32%, but whereas the ART is a significantly high, 149 babies of ROP in 237 were significantly high. But among them, the aggressive ROP were 58, the 18 were in natural conception and 40 were in ART. So this is also a significantly high. And plus spectrum was also 50 out of 78 in this ART baby, compared to this 28. So we can see that in ART, the spectrum plus spectrum were high, the high severity of ARPR were high. We treated them with the observation and with the following other conventional methods. So in the observation, in natural conception, 227 baby were recovered, but in ART babies were 86. So this again shows that the chances of treatment is required more in ART baby. Anti-VEGF injection, with only one baby has recovered with giving one anti-VEGF injection in natural conception, but otherwise in ART, two baby, but the baby it was not significant. Most of babies were treated with anti-VEGF with ROP laser, and the numbers required more in ART, 44 compared to 19 in natural conception. We did only ROP laser in 25 compared to 69 in ART babies. Again, surgery were required in ART babies, one baby. One infant need a repeated injection. One baby required ROP surgery, and one baby required augmented laser. That is also in ART babies. So these are the data. We can see that type of pregnancy comparing this. So we can see there's a more of a natural conception in the no ROP, where in more in natural conception compared to the ART. Again, we can see in stage 3 there is a more baby, 72 in ART baby compared to 28. Again, AP ROP with hybrid, there was a 40 babies in ART compared to 18 babies in natural conception. And again, the plus spectrum were also high in ART baby. So again, we have correlated this data with the gestational age also. So we can see in subtotal less than 32 weeks babies, the more ROP 120 out of 143 in ROP babies born with ART, whereas the 55 out of 106 in natural conception. Even we can see even more than 34 weeks babies, 6 babies had a in ART baby had ROP compared to 9 babies out of 64 in natural conception babies. So again, this ROP in relation to the birth weight, we can see babies born less than 1500 gram, 121 out of 147 in ART baby had ROP compared to 25 out of this. Again, with more than 200 gram, 2000 gram, 4 out of 9 baby had ROP compared to 15 out of 89 in natural conception babies. So this is the data we have analyzed the risk factors. So we can see the common risk factor were mainly respiratory distress system, neonatal septicemia, neonatal hypoglycemia, anemia. But these risk factors were more significant when if we have compared with the ART babies. So in our study, we have reported a significant increase in incidence of ROP among ART babies, 73.8% group compared with the natural conception, 32%. Incidence of aggressive ROP and plus spectrum disease has also been a significantly higher among ART babies, 74 to 73 respectively, compared to the natural conception babies. So the difference of outcomes is because of the assisted conceptions have been postulated to be because of gametes are exposed to a variety of drugs physically manipulated and nurtured in a potential hazardous condition, perhaps placed in inappropriate uterine. In our studied cohort, combined anti-VEGF and delayed laser therapy at least 2 weeks after the initial injection resulted in satisfactory refractive and structural outcome for children at 6 months of age. So conclusion, the data presented here shows a significant association between ROP in babies born of ART. Moreover, number of babies requiring ROP treatment is also significantly high in ART group. Combined ROP laser and injection has shown the rapid regression. There has also higher incidence of reactivation of disease in ART group compared to the natural conception and confluent ROP laser. Confluent ROP laser is a gold standard therapy for the reactivated ROP babies. So based on our results, we propose an ROP screening should be done up to gestational age of 36 weeks and birth weight of 2500 gram for babies those born by ART. ROP babies born by ART should be followed up closely and should be treated aggressively, and post-treatment they need special attention to look for recurrence. Although we need more data and more prospective studies to support this. Thank you, sir.
I have to few point I have to say that the incidence is not increased, I believe, but the awareness and screening,
Yes.
especially in the neonatologist, is increased. So increase the screening, so the incidence is automatically the number of patient is increased. Number two, in one patient you have mentioned you had not done you have given only injection.
Yeah. So
why not the laser? I don't know.
See, actually, a lot of
Subsequently,
studies are coming. Yeah.
After injection, you have to.
So,
There was any particular reason?
the one baby we have treated with this injection only, and it has recovered. One of the baby in a follow-up. Yeah, complete vascularization. We followed up till 56 weeks, and we saw that the vessels were growing, so we didn't do laser in that baby. In one baby in ART, we have given injection and we did laser, but again the recurrence were there. So we have repeated injection given in that baby, but later on giving one injection and follow up, that the baby got recovered. But in other baby, we have re-augmented the laser and then recovered after that.
And the third thing is the ARC babies belongs to higher socio-economic group. Okay. And the normal, I believe they are below the socio-economic groups. So they go more to the neonatologist, they do get admitted and might be detected. So this can be a major factor for the difference in the incidence of the this ROP in
that baby worries is one other reason also that the ART babies are prematurely they get delivered. They don't wait for 38, 39 weeks to for the delivery. Just they wanted the precious baby, so they usually this cesarean at 34, 35 weeks, and sometimes they prematurely they get delivered also.
Okay, it's nice.
Yes.
I had one child at 32 weeks, not ART, who present with the NVI. So have you had any patients who develop severe NVI and
Sir,
posterior zone
we
1
have a lot of
disease?
babies who were aggressive ROP, aggressive AROP. We got the NVI in the same. We
it's
get
quite
NVI
common,
commonly,
And it regresses
But after
beautifully.
giving injection, the NVI goes,
They regress. Which is the anti-VEGF you use?
We have mainly treated with the Avastin only.
Avastin only.
Sometimes some of the babies were the Razumab, some of the babies with the Centrix also, but most of the babies were treated with Avastin.
Dr. Shubho, you have, I think, watched few babies till 56 PMA. So, and few you have lasered within 2 weeks. So, is there any specific guideline?
Sir, actually, we have seen the other study that if you give injection followed by after 1 week or within a 2 week, they do laser. So, what we have done, we have waited for at least 2 weeks. Minimum gap we have given 2 weeks giving injection followed by laser. So, the minimum waiting period was 2 weeks. Followed by we have waited till that we can see the recovery is going on. Then once we can see that the baby has already reached to 37, 38, 39 weeks and the vessels are not progressing, so we did laser in those babies. Thank you, sir. Thank you.
Dr. Anna Shinai. No.
A very good morning to one and all. So I'll be speaking on non-contact ultra-wide field sweat source OCT biomarkers predicting treatment response of anti-VEGF in aggressive ROP. So these are my affiliations. I do not have any financial interest. So in the last 5 or 6 years, 3 things has changed. One thing is non-contact wide field imaging has helped us in diagnosis and treatment management in ROP, mainly because of the quickness of image capture and the non-contact nature. Another thing that has changed is smallest or the tiniest of babies are surviving. So even the 26 weekers and 28 weekers are having good neonatal care. So we are encountering more and more aggressive ROP. And the third thing that has changed is anti-VEGF has become there is a paradigm shift from laser to anti-VEGF in the last 4 or 5 years because of the better anatomical outcome and better even visual acuity as well as chances of refractive error is less. So these 3 things have changed in the paradigmly in the last 4 or 5 years. So the objective of this study is mainly to find out, is there any biomarker that could predict when a baby comes with an aggressive ROP like this? So yes, we know we have to give an anti-VEGF when the media is clear and there is no traction. But how do we predict when to call this baby or what will happen to this eye? Whether it go for a crunch phenomenon, whether it go for a peripheral avascular retina, or whether it will reactivate much faster than others. So the main objective was to find any biomarkers. Yes, there are studies that have shown fundus biomarkers and fundus fluorescein angiography biomarkers and also tear film based biomarkers, but all these are more subjective. So probably this is one of the objective way where OCT biomarkers for the first time has been tried in neonatal eyes. So the exclusion criteria, as I said, systemically unstable babies, or if there is any traction or previously treated eyes, or if there is any media haze or pupillary poor dilatation where we could not capture the images. So we included 40 babies and 80 eyes, and we followed this baby after giving anti-VEGF. We followed this baby up till 4 months of time, and the follow-up was 1 week, 3 week, and after that based on the judgment of the vitreoretinal surgeon who was taking care of the baby. So group 1 is a favorable outcome where the mature retina was reached. Group 2 is unfavorable outcome, that is crunch phenomena, reactivation of peripheral avascular retina. So is there any baseline OCT biomarkers that could predict which one of these babies with AROP go to group 1 or group 2? So the standard flying baby position where all the precautions of covering the baby with warm clothing was taken, and we had a neonatologist or a anesthetist in the ground or in the floor where we captured these images. And the Swepsode OCT biomarker, OCT image capturing device that the Opto Silverstone was used. It has a fast image acquisition of 0.4 second and also very high infrared radiation of 1050 nanometer with very good depth penetration and very fast image capture, and horizontal line scans were used. So we saw the biomarkers. So what we found out was two important biomarker that caused an unfavorable outcome was mainly your hyperreflectivity of inner retinal layers and your choroidal thinning. Whereas a good favorable outcome was seen if the retina was normal or if it had a hyporeflective cystic spaces. So for example, if you see this baby had a hyperreflective inner retinal layer with choroidal thinning, and after injection within 1 week it went for a crunch phenomenon with the traction. And the second baby we can see here, it also had a significant inner retinal layer hyperreflectivity, and the vessels did not progress beyond zone 2 posterior even after 3 to 4 months, and eventually ended up in laser after subjecting into general anesthesia. Whereas the babies which had normal retina without any changes or which had a hyporeflective cystic changes, as in this image, these babies tend to do well and faster progression after anti-VEGF injection. And with the anti-VEGF monotherapy of bevacizumab, that is 1/3 of the adult dose of 0.4 mg in 0.05 ml itself, they completely matured within a span of three months. So this is one image. If you can see, this is the same baby's different eyes. One eye had with normal retina. The other eye of the baby had hyperreflective inner retinal layer. So it had a poorer progression compared to the fellow eye. So even in same baby also, this was seen to be true. So one important thing is anemia is the strongest systemic risk factor we found out among all the systemic risk factors. So anemia correction should be an integral part of your treatment of babies. So what this study adds on is, yes, there are baseline non-contact ultra-wide field Swepsode OCT biomarkers along with the fundus imaging could be the one which could help us to predict which are the eyes which go for favorable or unfavorable outcome. Yes, hyperreflectivity of inner retinal layer, choroidal thinning should alarm the treating ophthalmologist that these babies need a much closer follow-up and these babies can go for an unfavorable outcome. Whereas cystic spaces and normal looking posterior pole, they have a much better favorable outcome with faster progression post anti-VEGF in AROP eyes. So this is our team from LVPI, and we had a lot of team because 20 team to take care of this advanced technology with tenderness of care. So thank you for giving the opportunity. Yes. Yes.
It's reached the posterior pole. It's like a retinal artery is getting affected at the entrance of you. So that's what's reflecting. So the ischemia is high. That's what you're trying to say. Am I right?
Absolutely, sir. So far, the point of view that people have looked at is foveal maturation and development. True. We have looked this in the form of, as you have mentioned, central retinal artery occlusion or central vein occlusion or ischemic diabetic macular edema. In that point of view, we have looked at it.
Right. Any other factors you looked at besides this hyperreflectivity? You found anything else?
Another thing is like choroidal thinning, sir.
Choroidal thinning.
Yes.
That's also a high risk factor.
Yes. Yes.
That also suggests a global ischemia is what.
Yes. Yes.
Great. I think it's a very good study. I think very great.
You said cystic changes. What does it indicate?
So
what do you see in a normal eyes?
Yes. So the landmark study by Maldon-Adaldehyde in JAMA has showed that 50% of the normal preterm babies can have cystic changes at the fovea. In our study, we have seen 23% of the babies having cystic changes. In their study, they showed that there is no connection between cystic changes and the severity of ROP. In our study, since we looked at the treatment outcomes, we found out that these cystic spaces could mean a good prognostic indicator. Even in vein occlusion, if you see cystic spaces like 500 microns, they immediately respond to injection. Even in BRVOs, if you see cystic spaces, means they will respond better to anti-VEGF.
Dr. Akash, two questions. One, you have a differential presentation in two eyes, in different eyes. in a single baby. So how can you explain that, first one? And second is that, do you feel that giving anti-VEGF in these patients where vasculogenesis is progressing, in these patients where you have a non-favorable outcome, did it change whether we can avoid anti-VEGF in these patients, or have you seen anything different in these patients?
Thank you for the question, sir. So, AROP eyes now the shift is towards anti-VEGF because we cannot laser till zone 1 R kids for various retinal detachment or refractive error. So, anti-VEGF is the treatment of choice. What I showed was even in the same baby, the baby which had one eye hyperreflective inner retinal layer, other eye normal, the other eye normal progress much more faster than the this eye. So, yes, something that we need to keep in mind and tailor make our follow-up. Lot of things has to come from here on regarding the follow-up, how to tailor make to these eyes. That is coming on our next publication, and we are finding.
You are using the word normal eye, but it's the immature, premature.
Sorry,
yeah.
yes.
So you are using every other normal eye.
Yeah,
I think looking at this thing, they are not normal eyes.
Yes. Agreed, sir.
Thank you, sir.
We'll go ahead with next one.
Thank you.
Nice presentation.
Thanks.
Madam, are you ready? Please. This is the fifth paper.
Good morning, everyone. My study was on the foveal microvascular changes following post-pars planar vitrectomy with silicone oil tamponade. So I have no financial disclosures. Silicone oil is considered to be an ideal substitute material for the vitreous. The success rates of vitreoretinal surgeries have markedly increased since the introduction of silicone oil. Silicone oil is thought to cause many complications. Previous studies have shown there are also changes in the retinal thickness and the fovea avascular zone areas. We have evaluated these changes vary with the duration of silicone oil tamponade. The aim of the study was to study changes in foveal vasculature using OCTA in eyes undergoing PPV with silicone oil tamponade for egmatogenous retinal detachment. Primary objective was to study the foveal avascular zone area changes both in the superficial and the deep layers, and secondary objective was to study the central foveal thickness changes. So ours was a prospective study conducted at Bajan Singh Eye Hospital, Nagarkoil. We had a sample size of 30 eyes. Eyes with retinal detachment were taken as the case group, and the fellow eye was taken as the control group. We included patients with unilateral fresh RRD and who had a duration of less than 1 month, eyes with diabetic retinopathy, uveitis, macular edema, macular hole, high myopia, glaucoma, PVR greater than grade C, optical media opacity that could interfere with image acquisition, silicone oil emulsification, epiretinal membrane or redetachment cases were excluded from our study. Various parameters including the BCVA, intraocular pressure, the fundus examination, then central foveal thickness using SDOCT and foveal avascular zone measurements of the superficial and the deep layers were captured using OCTA. All investigations were performed with silicone oil in situ at post-op 1 month, 2 month and 3 month and 3 months following silicone oil removal. The obtained parameters were compared between eyes with retinal detachment and the fellow eyes. So the surgical procedure was a standard 3-port 25 gauge pars planar vitrectomy done by a single surgeon. Phacoemulsification with IOL implantation was performed simultaneously in all eyes with cataract. The cortical vitreous was removed extensively and the base was shaved using scleral indentation. Laser photocoagulation was performed around all breaks and 360 degrees. Surgery was completed by air oil exchange. Sclerotomies and were closed with 8-0 vicryl suture. All patients received the same brand silicone oil with 1000 centistokes. Face down position was given for 2 weeks post-operatively. After ensuring that the retina was attached at 3 months, the silicone oil removal was done. So statistical analysis was done using SPS software. A pad t-test was done to compare the variables. P-value of less than 0.05 was considered as significant. So this is a demographic data. The mean age at presentation was 58 years. The axial length mean was 23 millimeters. Spherical equivalent was minus 1.56. Then there are a few patients who had diabetes and hypertension. So the baseline characteristics show the preoperative best corrected visual acuity. The mean duration of retinal detachment before surgery were 12 days. There were 3 patients who had a macula on retinal detachment, and 27 patients had a macula off retinal detachment. The lens status, 40% of the eyes were phakic, 60% was pseudophakic. The extent of RD was involving 1 to 2 quadrants in 4 eyes and 3 to 4 in 26 eyes. The single break in 6 eyes and multiple breaks in 24 eyes. Coming to the intra-op parameters, the duration of surgery were around 90 minutes. Combined cataract surgery was performed in 12 eyes. Perfluorocarbon liquid was used in 8 eyes. ILM peeling was not done in any of the eyes. The volume of silicone oil used was around 5 ml. The duration of silicone oil tamponade was around 3.2 months. So this is a graph showing the best corrected visual acuity at pre-operative month, first month with silicone oil, second month with silicone oil, and third month with silicone oil, and 3 months following SOR. So this blue indicates the study group. We see that there is a improvement in visual acuity at first month, which is remaining almost stable following SOR. So this is a graph showing the central foveal thickness. In the control group, we see it is remaining, but in the study group, there is a decrease in the central foveal thickness at 2 months of silicone oil tamponade, which is remaining stable even after SOR. The foveal avascular changes in the superficial and deep capillary plexus, we see that the foveal avascular zone area has increased. So at post-operative 1 month, there was a statistically significant difference in the p-value between the study and the control eyes, but the central foveal thickness, the foveal avascular zone at the superficial and deep layers were insignificant at post-operative 1 month. Even though there was an increase, the difference was not significant. At 2 months, we see that all parameters, there is a statistically significant difference in foveal thickness and in the foveal avascular zone areas. At 3 months, it has become even more significant. After silicone oil, the difference has remained the same and the difference has become statistically significant. To compare between pre and post SOR, we see that there is no difference even after 3 months of silicone oil removal. The foveal thinning has still remained the same, and the increase in foveal avascular zone has still remained the same even after 3 months of silicone oil removal. So significant thinning with increase in silicone oil duration. There is least foveal thickness recorded at 3 months of silicone oil in situ. We see there's an increase in foveal avascular zone. There's a gradual increase in the size of the foveal avascular zone with silicone oil tamponade duration. But there are few limitations. We have included both macula on and macula off retinal detachments. So whether these changes were per se because of the retinal detachment or because of the tamponade should be studied in detail. So to conclude, these changes were found to progress with increase in duration of the tamponade. Hence, earlier silicone oil removal might reduce these changes. Thank you.
You said reduce thickness of the fovea over a period of time. That means there was edema and it is coming back to normal, or it is leading to thinning of the fovea?
Thinning, sir. Compared to the other eye, it is thinning. Yes, thin.
And control group was other eye?
Yes, sir. Yes, sir. Yes, sir. Sir, patients with macular edema were excluded from our study. Yes, sir. Yes, 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 sir.
If
Yes, sir. Oh, okay.
and you say early, how early then you plan? Because you are already 3 months is fairly early for most surgeons. So what is your recommendation? Early means 2 months or 1.5 months?
So we still need more study with a larger sample size to validate that, sir.
But are you planning early removal at your center?
Not yet, sir.
I have a basic question. At least if you remember 6 eyes, you said there's only one break.
Yes, sir.
Why 360-degree laser in those eyes? The inflammation itself can create a problem. With that added excess laser, why 360-degree laser when one single break? And where was the one single break? Why something like that. All these eyes have PVR or no PVR?
Had my more than grade C were excluded, but some eyes did have PVR.
So that adds on against other parameters.
Yes, sir.
Thank you, madam. I invite Dr. Hema VK for her presentation.
Good morning, everybody. My topic of today's discussion is analysis of anatomical and functional outcome in optic pit maculopathy surgeries. Optic disc pit was first described by Waite. Incidence is 1 in 10,000, and maculopathy is seen in 25 to 75% cases of optic disc pit. The origin of fluid is still controversial. There are two major theories. One is from vitreous and other is from cerebrospinal fluid, but there's a direct communication between the subarachnoid space and subretinal space. Again, treatment modalities are controversial. Vitrectomy is the preferred one. Plugging the optic disc pit with different materials like graft like autologous platelets and scleral graft are tried. Ours is a retrospective study of 13 patients done from 1st September to 30th September. A detailed history and ocular examination was done. All surgeries was done by a single surgeon. Previously, we used to do 23 gauge vitrectomy. Now we have moved on to 25 gauge. PUD induction was done and a graft 0.5 into 0.5 mm was taken from supratemporal sclera and plugged into the optic pit, and careful fluid oil exchange was done. Coming to the result, we had 5 males and 8 females. All cases were unilateral. One patient had retinochoroidal coloboma in the other eye. Other patients had normal eyes. Mean preoperative vision was 636. Median preoperative vision was 636, which improved to 618 at 1 year. Coming to the OCT changes, when evaluating the disc, we could see there was a hyporeflective space inside the optic disc pit, which was postulated as collection of fluid, and we could see there was a connection from the optic disc pit to the inner retina. This figure also shows a connection from the optic disc pit to the inner retina. But post-operatively, this is the scleral graft of one patient who was followed up at 1 year. We could see that the tract has disappeared and the fluid has decreased. Coming to the macula findings, we could see that 76 patient had outer retinal schisis and 72.2 had inner retinal schisis. The fluid first appeared in inner retina in all cases. Post-operatively, fluid resolution was seen first in inner retina and the outer retinal fluid was last to disappear. Central macular thickness, there was a reduction of 35 to 50% in 40% of cases and 50 to 70 in 30% of cases. Normal OCT was seen in 10% and attached retina with thinning was seen in 20%. When coming to the complication, what we see was raised intraocular pressure was seen in 3 patients, which was managed with anti-glaucoma medications. 1 patient each was there with cataract, rhegmatogenous RD, recurrence of edema, and dislodged plaque. For rhegmatogenous RD, we did a silicone oil in situ, and this was the patient who had recurrence of fluid. At 1 year, the patient had a drastic decrease in central macular thickness, but at 2 years, we could see there was recurrence of edema, and which was treated with topical steroids. And the patient who had a dislodgement of plaque had similar decrease of central macular thickness. So what we found was that in OCT, there was a fluid tract which was seen from the base of the pit to inner retina, and post-operatively, the inner fluid was first to disappear and also first to appear and also first to disappear, which was in favor of the CSF theory. But none of our patient had PVD and all patient was induced PVD, and there was no vitreomacular traction clinically or in OCT. So we made a humble attempt to derive the pathogenesis of optic disc pit maculopathy, which was depicted through this animation. So optic disc pit is a failure to closure of the embryonal fissure. We can see when the optic disc pit develops, there is a fluid collection pocket which is formed beneath the pit, And when the egress of fluid to the retina may not be an acute process, it can be a chronic process. In cases like maybe a CSF fluctuation, the fluid slowly egress into the inner retina and the retinal thickness increases. But when we are putting a graft into the pit, we can see that there is a mechanical obstruction of this path and the central retinal thickness decreases. So what we like to conclude is that optic disc pit maculopathy may be a CSF in origin. Scleral plug offers a mechanical closure than an anatomical closure, and more discussion has to be needed in this entity because it's seen, as we have seen, the mean age group is 35 years, and also 25 to 75% of patients with optic disc pit can develop maculopathy later. Thank you. So we initially, when we were doing a 23 gauge, we could insert a plug more than 0.5 mm into 0.5. But for the ease, we have taken at 0.5 into 0.5 mm for 25
No, the
gauge.
reason is, you say it's a mechanical closer.
Yes, sir.
So you need to have a snugly fitting plug there.
No, sir.
If it is a larger one, again you're going to cause a lot of nerve fiber layer damage. If it's less, it's going to dislodge. So you need to have a precise dimension how you decide that.
So we also believe not only because of the mechanical effect, because of the manipulation also, some obstruction in the tract has been happening. Because for one case we saw that even though the plug was dislodged, there was a result was similar. So maybe not only the plug but also manipulation also might have caused a change in the tract.
You also know there's a fluctuating course over a period of years, natural course we know.
Yes, sir.
So really you think that with surgery help, or it's like a natural course? Probably if you reduce sometime, as you say, CSF pressure and all those things, and we have seen that. So how you are sure about it? Your technical surgery works in those cases probably.
Yes, sir. Definitely, we have seen a decrease in CMT, and also base 3-line in 40% cases had 4-line increase, which is a good result. And this is so in young patients. So I think we can call for a surgery than observing.
Dr. Hema, did you have any control group in this study?
No, sir. Which all patient who had this optic disc maculopathy, we had undergone surgery. But
what Sarah was telling that
yes,
whether
sir.
you have a spontaneous closure of the optic pit, even without giving a scleral plug.
Yes, the thing is, which patient, some patient who had denied surgeries, only we didn't do surgeries. But when we follow up, no, they really had an increase in central macular thickness. But when we did surgery, none of the patient had an increase, no patient had worsening, and 40% had better reduction in CMT.
No,
And what was the nature?
No.
So what was the nature of the graft? Autograft?
Partial thickness scleral graft, sir.
Okay.
Taken from supra. Sir, 25 gauge, we can put a 0.5 into 0.5, sir.
Okay.
The autologous graft.
Yes, sir.
Same patient.
Yes, sir. Same patients.
Last question I had, that since you brought out a very important point which I caught, that you feel that the manipulation in the pit can close the hole. So I think there's a way, like, means you could consider that rather than putting a graft, like, you can use a Finis loop or a Thanos diamond duster and try to, sort of physically close that, or, what about that idea?
Sir, that is one patient we had only since 1 year follow-up. So we don't know what will happen in future.
Correct.
But that's one of our postulates, sir.
Okay, great.
And what's the thickness? How do you determine the thickness of the graft?
Partial thickness around below less than 40% we can take, sir.
Thank you, madam.
Thank
I call
Thank you,
Dr.
sir.
Vishal Jadhav.
Good morning, everyone. Myself, Dr. Maheshwari. I'll be talking on our comparison of outcomes of pars plana vitrectomy with inverted eye-lamp flap versus scleral graft for optic disc pit maculopathy. So, ONH pit is a rare congenital anomaly with prevalence of 1:11,000, thought to result from failure closure of fetal fissure. Appears as a small hypopigmented gray-white depression, usually located in the temporal part of the optic disc. It is usually asymptomatic. But pit maculopathy is characterized by the presence of retinal schisis and serous macular detachment, seen in up to 25 to 75% of the patients. The treatment options include spontaneous resolution, laser photocoagulation, macular buckling surgery, inner retinal fenestration, and pars plana vitrectomy with plugging of the pit. The aim of this study was to evaluate the anatomical and visual outcomes in optic disc pit maculopathy following PPV with inverted iLM flap versus scleral autograft. It is a retrospective study. Inclusion criteria was patients who underwent this procedure between March 2017 to July 2022. People who had a coexisting ocular pathologies affecting vision and lost to follow-up before 1 year were excluded from this study. The preoperative evaluation included slit lamp biomicroscopy, fundus examination, OCT, Snellen's BCVA, IOP, and informed consent was taken from all the patients. Surgery included pars plana vitrectomy with either inverted ILM technique or scleral graft technique, and post-operatively it was seen day 1, 15, 30 and 3 monthly for 1 year. This is a video demonstrating the ILM peeling technique. After pars plana vitrectomy and induction of the PVD, BBG dye is used to stain the ILM. After this, supero-nasal to the macula, ILM flap is raised. Foveal sparing ILM flap is raised and then it is tucked into the optic disc pit. Careful fluid air exchange is done nasal to the disc, and after confirming that the ILM is in place, gas tamponade is placed. So coming to the scleral graft technique, pars plana vitrectomy with induction of PVD was done, following which a partial thickness scleral graft was used, was dissected, and then it was sized according to the cutter width which we used to measure approximately, and then it was placed over the optic disc pit. Following which, careful fluid air exchange was done, and confirming the graft in position, gas tamponade was advised and prone position was advised for 2 weeks. Coming to the results, the ILM peeling technique included 10 eyes and the scleral graft technique included 11 eyes. The mean age was comparable in 2 groups with 27 years, and mean best corrected, this is a box plot demonstrating representation of visual acuity at baseline and 1 year post-operatively. In scleral graft group, the baseline visual acuity at the presentation was 0.58 logmer, improving to 0.53 at 1 year, and in ILM peeling group, it was 0.91 logmer, improving to 0.58 logmer. There was statistically significant improvement in ILM group, but since the baseline visual acuity was worse in ILM group, this was not statistically significant between the groups. This is representation of central macular thickness at baseline and 1 year. In scleral graft group, it was 1220 microns, improving to 276 microns. And ILM peeling group, it was 804 microns, improving to 273 microns. There was significant reduction in both the groups, but there was no statistically significant difference between the groups. So these are some OCT images pre-operative, which was treated through the fovea showing schisis of inner and outer retinal layers treated by ILM flap, and post-operatively at 1 year showing resolution of subretinal fluid and minimal inner retinal schisis. This is a patient with pre-operative OCT through disc and fovea showing optic pit with schisis treated with scleral graft at 1 year showing near total resolution of the SRF. So coming to the discussion, 21 eyes of optic disc pit maculopathy were studied. They were unilateral and located in the temporal half of ONH in all patients. Incidence was seen equally in males and females. The purpose of this treatment was to produce a permanent barrier for fluid migration out of the pit. And one patient had a scleral graft displacement, which was treated by repositioning of the graft and silicone oil injection. So coming to few literature research, the EVRS study for this optic study, PIT study showed 25 surgeons around 12 countries with 95 eyes, showed higher rates of resolution of SRF and IRF with pars plana compared to the laser. And another study by Naresh Babu et al. Was a retrospective study which compared between ILM peeling, ILM flap and scleral plug, which showed better surgical outcomes if the pit was plugged. So to conclude, the modified techniques of pars plana vitrectomy and plugging of pit using foveal sparing inverted ILM flap and scleral graft for the treatment of pit maculopathy results in good anatomical and functional outcomes. Statistically, both techniques are similar and with regards to surgical outcomes in terms of central macular thickness, serous macular detachment resolution, and visual acuity. And surgical intervention may also help in the long-term stabilization of the disease with faster resolution of the SRF. Thank you.
Basically, looking at your study, still now previously we discussed what is the source of SRF, subretinal fluid you think here?
Sir, as she already said, it is either CSF or vitreomacular traction. Since I cannot postulate what is the theory, but we have induced PVD in all the cases. So we try to eliminate the factor which is vitreomacular traction, vitreopit traction, and since we are plugging, even the CSF source has.
That's eyes where ILM is covered. That's why you said better outcome, right?
No, that is because two patients had worse visual acuity at the time of presentation in ILM group. So they had worse visual acuity at the time of presentation. But both the group improved significantly. Since the baseline visual acuity in ILM group was worse, there was difference between the two groups. Otherwise,
you think other group has a ceiling effect?
Both the groups has a ceiling effect.
So now you move to which techniques in your study? Which is the technique?
Sir, this was. There is no based on whether at the time of presentation or at the time, it is based on surgeon's preference. Time of presentation.
If I had to walk out of this hall, what you want to take a muscle, which technique I should follow?
It is based on the comfort of the surgeon. Both the techniques are equally effective because neither of the visual acuity pre-op and post-op was affected by the type of the group and resolution of the SR. Since we are taking partial thickness, I think it should.
We are damaging some anatomical structure there. ILM is a part of your surgery. We are increasing one more step. And offer you, I prefer that ILM fitting better.
Totally, surgeons feel so. Totally, surgeons feel so.
Sir, Ramesh, one thing that graft, how do you feel? What is the adhesion property? How it is getting adhered to the pit? And you have one patient who got dislodged.
Yes,
so I think it's technically there's a high possibility will dislodge because it's not having any initial adhesion. So what actually is your technique? How do you feel that it's getting adhered to the pit?
I think it's because of the autologous graft. I think it's mechanical, it occludes and then stays in position. And all the patients who were not dislodged after 15 days had no dislodgement post that. So the mechanical plugging is what I feel.
We'll move to last case. Thank you very much.
Thank you so much.
Last case.
Now the last speaker.
Should I start? Yeah. Good morning, everyone. I am presenting a rare case of juvenile X-linked retinoschisis in a young male. X-linked juvenile retinoschisis is a condition characterized by symmetrical bilateral maculopathy leading to impaired vision that begins in childhood. It is seen almost exclusively in males with a prevalence of about 1 in 15,000 to 1 in 30,000. It arises as a result of inherited defects in Muller cells. It occurs due to splitting of the RNFL from rest of the sensory retina, in contrast to acquired retinoschisis, where splitting occurs at the outer plexiform layer. Inheritance is X-linked recessive, with RS1 being the implicated gene in most cases and the protein being retinoschisin, which is involved in intercellular adhesion. I am presenting a case of 17 years old male who presented to IOPD with complaints of diminution of vision in both eyes for about 4 years. The patient was apparently well 4 years ago when he developed diminution of vision in both eyes, which was insidious in onset and progressive in nature. It was not associated with pain, redness, watering, or discharge. History of spectacles use was present. There was no history of diabetes, tuberculosis, or any other systemic illness. There was no history of previous ocular surgery or trauma. There was no significant family history. Personal history: vegetarian with normal sleep and appetite, normal bowel and bladder habits. There was no history of smoking or drinking. On general physical examination, patient was well nourished, conscious, alert, and well oriented to time, place, and person. His vitals were stable with pulse rate of 72 beats per minute, blood pressure of 126 by 78 mmHg, respiratory rate of 14 per minute. He was afebrile to touch. There was no pallor, icterus, cyanosis, clubbing, and edema. On ocular examination, best corrected visual acuity was 624 in right eye, 618 in left eye, with +1 diopter square in both eyes. Head posture was within normal limits, head nexa was within normal limits, eyeball was normal in position, normal in alignment, and ocular movements were free and full and painless in all directions of gaze. Conjunctiva was normal, showed no congestion, chemosis of foreign bodies. Sclera episclera showed no discoloration, nodule, or laceration. Limbus was normal, no vascularization pigmentation seen. Cornea was clear in both eyes. Anterior chamber showed normal depth, no cells, blood flare or hypopyon seen. Iris was normal in pattern and pigmentation. Pupil was 3 mm round, responding to direct and consensual light reflex. Lens was phakic in both eyes. Fundus, disc margins were sharp in both eyes with CD ratio 0.3:1. Foveal schisis was seen, giving the appearance of spoke-like stria radiating from the foveola. IOP was 13 mmHg in right eye and 14 in left eye. These are the fundus images of right eye and left eye, showing foveal schisis, giving the appearance of bicycle wheel-like or spoke-like stria radiating from the foveola. And these are also the fundus images, same patient. Investigations, a provisional diagnosis of juvenile X-linked retinoschisis was made, and he was advised to undergo bilateral OCT, macula, and FFA for documenting maculopathy and its progression. OCT in both eyes showed intraretinal foveal schisis with cystic spaces. As we can see in this image here, FFA could not be done as patient did not give consent to get it done from outside, and we did not have the facility working at that time in our institution. Management, the patient was prescribed oral acetazolamide BD and topical eye drop dorzolamide TDS to reduce foveal thickness and improve visual acuity. He was educated to avoid high impact sports due to the increased risk of retinal detachment. Genetic counseling of the patient and his family was done. He was followed up at short intervals to look for secondary complications. At 1 month, his BCVA was same with no secondary complications. Conclusion, juvenile retinoschisis is a rare disease belonging to a group of hereditary vitreoretinopathies and is characterized by bilateral maculopathy. Inheritance is X-linked recessive. Progressive maculopathy often leads to poor prognosis. Visual acuity often deteriorates during the first 2 decades and then stays stable until the 5th or 6th decade. It has been seen that clinical course of disease gets complicated by vitreous hemorrhages or retinal detachment in approximately 5% of all affected males, where we might need surgery. Although we have made significant progress in understanding of the disease still has many unresolved issues that require further study. Thank you.
Is there any family history of the same problem?
Actually, he did not give any family history. Maybe it was unknown, or maybe it is because of asymptomatic female mother of the patient. Because mothers are usually asymptomatic, patient might not be knowing.
Did you ask for a genetic test or gene mapping or something?
Yes, sir, but it was very costly and we could not get it done actually.
What you see on FFA, what you are expecting on
Yeah, sir. On FFA, we are expecting window defect in later stages maybe due to RP atrophy in later stages. And that's how we can differentiate from cystoid macular edema as well, where there is leaking in petaloid appearance.
leakage in a macular edema? Here you won't get leakage.
Here we will get window defect due to RP atrophy, sir.
What are the gene studies going on in X-linked? Are you aware?
Yes, sir. Yes, sir. There are 2 NIE and AGTC. There are 2 trials going on for. Sir, one of them showed like improvement in cavities, foveal schisis cavities that showed decrease in the cavities, but not much success due to inflammation. Ocular inflammation was there, and also with the same AGTC was halted because of the ocular inflammation that went, with not much of success there.
Thank you, madam. Any more questions?
Thank you.
Thanks to all the participants, my colleague.